Professor Gilles Montalescot, Assessment of an Education and Guidance Program for Apixaban Adherence in Non-Valvular Atrial Fibrillation, the randomized AEGEAN study.
Thank you, Dr. Huntman. So let's start. Vitamin K antagonists have several drawbacks limiting their use, and it includes, of course, the need for frequent anticoagulation monitoring and dose adjustments. The NOACs, the non-vitamin K oral anticoagulants, have overcome many of these drawbacks, including the need for anticoagulation monitoring. But because of this, the adherence to NOACs could be suboptimal because they do not require now routine monitoring in anticoagulation clinics. So we wanted to study here the impact of a proactive educational program on adherence to anticoagulation therapy for SPAF using one of these NOACs here, apixaban. So the primary objective of the study was to assess the impact of the educational program on adherence in patients taking apixaban for SPAF, and this was assessed at 6 months follow-up using an electronic monitoring device called the helping hand. We had secondary objectives. We looked in particular at persistence, and persistence is the word for discontinuation. This is what you see in the big clinical trials reporting results for AFib patients. When patients discontinue drugs, actually this is persistence. We looked at predictive factors associated with non-adherence to try to identify the patients at risk of non-adherence. And of course, we looked at clinical events in this study. So the design is pretty simple. This is a randomized study for atrial fibrillation patients requiring anticoagulation. And these patients were treated with apixaban and randomized for a standard of care with apixaban, or were randomized for apixaban with an additional educational program. And this program included booklets given to the patients explaining the disease, explaining the treatment, explaining the symptoms of stroke. They were provided with reminder tools, keyrings, SMS, smartphone applications to make sure that they would take the drug at the right time every day. And most importantly, they were in contact with the anticoagulant clinics that were developed in the 6 participating countries in Europe, anticoagulant clinics that were used for these patients on warfarin for AFib. So we use these clinics and the personnel to educate and inform the patients on the disease and the treatment. So the clinics called the patients, and the patients could call the clinic anytime there was a hotline, and they could be informed and their questions could be answered. There is a second phase of the study. After 6 months, these patients in the educational program are re-randomized to interruption of the program or continuation of the program for 6 more months. This phase of the study is still ongoing, so I will not present the results of this second phase of the study. We had stringent definitions for adherence, of course, and as you know, apixaban is taken twice daily, so a day of adherence typically would be when apixaban is taken twice daily as prescribed. If only one tablet is missed in isolation and the drug was taken the day before and the day after, it's still a day of adherence. A day of non-adherence typically is when 2 consecutive tablets are missed within the same day, or when one tablet was missed for several days. And these situations corresponded to days of non-adherence. And we had actually conservative definitions, I believe, for this adherence evaluation. Persistence was defined as the absence of permanent discontinuation. We used an electronic monitoring device to measure adherence, and this is what is called the helping hand. And you can see the blister inside the device, and each time the patient took a pill, the day and time were recorded. So we had a very good idea of when the pills were taken and if they were taken properly. This is the primary endpoint looking at adherence, and you can see immediately that there was no impact whatsoever of this educational program on adherence to treatment. You can see also that the rate of adherence in this study is very high. 94% at week 4, 92% at week 12, 88% at week 24. So, of course, it is more difficult to show an impact of such a program when you have high adherence rates with here apixaban. We looked at persistence, and it is about the same story. The rates of persistence are very high. You can see that it's 91% at 6 months, and there is no difference between the two groups with or without education and additional information provided to the patients. We looked at clinical outcomes, and this study of 1,100 patients is not powered, of course, for clinical outcomes, but these events were adjudicated, and I think they confirm what we have elsewhere in the study. 4 deaths with a standard of care, 6 with educational program. If anything, stroke, TIA, systemic embolism, we had, numerically speaking, slightly more events with educational program. No difference for myocardial infarction, no difference for major bleeding. So globally, neutral results also for clinical outcomes. So the conclusions would be that the study shows a high adherence rate, 88% in the first 6 months of apixaban given twice daily for the treatment of SPAF. We have also a high persistence rate, 91%, over the same period with apixaban. There was no additional value of a proactive educational program on adherence with this treatment. Long-term adherence, as well as the value of an educational program beyond 6 months, is being evaluated by the second phase of the AEGEAN study. Thank you for your attention.
Thank you, Dr. Montalescot. The AEGEAN study is open for questions now. In the back, please.
Yes, Sue Lyon, Primary Care Cardiovascular Journal. Could I ask if the anticoagulant clinics are in secondary care? Because a lot of clinics in this country would be in primary care.
Yeah, these clinics were very different from country to country. UK actually participated to this study, and we used the systems as they were in each country. So we used the anticoagulant clinics with personnel to inform and educate the patients. And in Germany, for example, we had another issue. Some places had no anticoagulant clinics, so they were created for the trial, and personnel was hired for the trial. So different settings according to the country, but every time there was a contact between the staff and the patients during the 6 months period.
So presumably the standard of care in each country differed then?
So you know how it is in this country. In my country, in France, that would be anticoagulant clinics driven by the hematologist. In Italy, that would be also driven by the hematologist. In Germany, that would be more by the cardiologist. And the personnel would be formed by these physicians, of course.
So sorry, I asked if the standard of care differed between countries, because that would...
The standard of care is different between countries for warfarin, and there is no standard of care for NOACs. This is the first study to use this system for a NOAC in AFib.
But surely when a NOAC is prescribed, the health professional would stress the importance of adherence.
Yes, that's the standard of care. You get a prescription, you get information from your physician. What we did in addition is to provide tools, booklets, and this contact with the anticoagulant clinic, which is not required for the patients on NOACs.
Okay, thanks.
Ed Sussman. Hello.
Go ahead.
Go ahead.
Ed Sussman with MedPage Today. When you first thought about this study, what did you think the adherence rate would be among those getting standard of care? What were you basing your assumptions on?
That's an excellent question. There is absolutely no data in the literature to tell you what is the adherence rate on NOACs when the patient is out of the hospital. What you get from the literature is the rate of discontinuation of treatment, which is something different. It does not tell you how the drug is taken. So we had no idea. We expected something around 80%, and we feared to have less than 80%. Actually, that was a very good surprise to see that in this study. Of course, the patients are somewhat selected because they participate to a randomized study, but at least in this study, the rates were pretty high and pretty good, which is good news.
And do you have any idea as to why the rate of adherence was so, really unexpectedly high?
It's high probably because the treatment is easy to take, easy to remember. Of course, when you explain to a patient that is going to participate to a study looking at adherence, it tends to probably overestimate adherence. But you can see also that over time, the curves are going down. It's only 6 months. We would have 1 year follow-up. So, these curves will still go down a little bit. I don't know how much. So stay tuned. We will come back in 1 year, and we will tell you what it is in 1 year.
And how much more expensive is it to do the educational program than to just give the patient advice and the prescribing information?
If you think that the anticoagulant clinics exist and that the personnel is paid already for the patients on warfarin, the other cost would not be important. But for example, in Germany, where we had to build these clinics for the study, of course, it has a cost.
So we'll need to move on to our next presentation. I'm sure Dr. Montalescot will be available.